First, for our final keynote of the conference, we are delighted to have comments from Dr. Jean Kaseya. Dr. Kaseya was unable to join us in person today, but has kindly pre-recorded his remarks. Dr. Kaseya is the Director General of the Africa Centers for Disease Control and Prevention. He is a Congolese physician with over 25 years of public health experience, having held pivotal roles at both national and international levels. After Dr. Kaseya's remarks, we will have discussants from multiple regions of the world to pick up on themes and, importantly, identify opportunities for this particular moment. Our discussants will be Dr. Samin Siddiqui, who is professor and chair of the Department of Community Health Sciences at Aga Khan University in Pakistan. Former WHO representative in Lebanon and Pakistan, Dr. Siddiqui has over 30 years of experience in governance, leadership, and health system reform. We will have Dr. Sanam Roder-Dewan, who is an associate professor of community and family medicine and associate professor at the Dartmouth Institute. She also serves as technical advisor for health system quality at the World Bank Group. Dr. Roder-Dewan's research focuses on improving primary care delivery, health system design, and quality of care in global settings. Dr. Luke Allen, who is co-director of Global Primary Care and Future Health Systems at the Nuffield Department of Primary Care Health Sciences at the University of Oxford, a family doctor and global health advisor. Dr. Allen has worked with the WHO, World Bank, and UNICEF, and is focused on advancing equitable, high-quality health systems worldwide. And last but not least, Dr. Emma Iriarte, who is the executive secretary of the Salud Mesoamerica Initiative at the Inter-American Development Bank. Dr. Iriarte leads regional partnerships aimed at improving maternal, newborn, and child health outcomes through performance-based financing and health system innovation. Afterwards, Dr. Mark Huffman will again moderate some exchange. Great.
Excellencies, colleagues, dear friends, and fellow champions of health systems, it's a privilege to join you today, even virtually, for this inaugural Science for Health Systems Conference. I sincerely thank Professor Margaret Crook and the Quest Network for organizing this timely and essential dialogue on innovations in quality and performance measurement for the well-being of the global health and humanity. Across Africa, we are witnessing a pivotal moment in health system reform. The COVID-19 pandemic and a series of increasingly public health events such as Mpox, cholera, Marburg, Ebola have exposed vulnerabilities in health systems, but in turn has driven innovation, resilience, and change. To ensure health sovereignty in Africa, we are focusing on data, digital transformation, and research leadership. Data among other strategic components. Evidence is more than just data. It acts as the compass guiding reform, the foundation of accountability, and the link between policy and impact. Evidence is not about numbers on a spreadsheet. It's about whether a mother survives childbirth, whether a child gets a vaccine on time, and whether a pandemic is detected early. Data and quality are the guarantees that every dollar, every worker, every innovation delivers real impact. In 2024, only 38% of Africans' population has access to reliable internet connectivity. This digital divide limits our health system ability to function in real time and denies community workers the tools they need to save lives. I'm proud to announce that Africa CDC is signing a landmark agreement with Starlink that will extend connectivity directly to community health workers and strengthen linkages with national health systems. This isn't just about technology. It's also and more about equity, access, and ensuring that no community is left behind in the delivery of health systems across our continent. Excellencies, dear colleagues and friends, let us use this conference as an opportunity to challenge assumptions, to exchange innovations, and to propose practical, evidence-based actions that improve performance ensure sustainable progress, and enhance lives and livelihood. We need evidence to allocate resources fairly and effectively, generating tangible results and impact. Most importantly, we must use the evidence available and interpret it impartially, free from personal bias, and we need to make that as a way for global decisions. Let me thank all of you for your attention and wish you successful deliberations.
And as the discussants are coming, I loved what Dr. Kaseya had said, welcome health system champions. I went to the University of Notre Dame, which is renowned for its football program, and every time the players go out onto the field, they tap a sign before and it says, play like a champion today. So we're gonna play like health system champions today. Go Irish. Okay, so thank you very much for being up here, and we'll perhaps go in the order in which Dr. Lewis introduced the panelists. So I'll start with Dr. Siddiqui, and the same question for the other panelists is, what is a theme that you heard in the recorded message from Dr. Kaseya that resonates with you and reflects upon the work that you do? Dr. Siddiqui, please.
Thanks very much. Good morning to you all. So I think what came out strongly with the brief intervention from the colleague from Africa was around data, and I think this has been resonating and this has been reverberating over the last couple of days. And the perspective that I see from a data is that, in our countries, while there will always be research and surveys, but strengthening information systems will be critical for use and then decisions, basically. And I would like to bring out two kind of challenges from my experience and then some achievements as well, very briefly. So one of the big challenges that I see in our countries is the fragmentation of these information systems. We are responsible, but partly also our development partners, the Global Fund and Gavi, they all want to have an information system for TB and HIV and malaria and so on and so forth. And I think that leads to a lot of fragmentation. So I think that's a gap that has to be addressed. And as we digitize our systems, we may end up with multiple systems. And somebody didn't like the word interoperability, but that is certainly a challenge in my country. The second one, I think, is the lack of data that we have for what happens in the private sector, at least certainly Mike, and many countries in South Asia for that matter. We really don't know what is happening. Our information systems do not necessarily capture what is happening. And I think that's a gap. Many countries, people, first point of contact is not the public sector, it is the private sector. So I think those two would be my challenges that I would like to sort of bring in. But on the more positive side, I think you saw the presentation that you gave, the slide that Tracy you presented, is the use of data for monitoring purposes. And I think that's a very positive development that is certainly happening. And the other one that I'd like to touch on is that one of our big provinces, which is Punjab, which has 125 million population, has moved towards the establishment of an electronic medical record system, which I think in a resource constrained setting is a very big achievement. It has challenges, it's not of great quality, but I think it's a very good step forward. And I just want to leave you with one figure. So the antenatal visits in the province in the year 2023 was 7.5 million. And that's big data. And that's the kind of data where we need to improve the quality, and we also need to be able to handle and analyze it for our decision makers for better use and informed decision making.
Thank you, Dr. Siddiqui. Dr. Roder-Dewan, and after the panelists speak, we will have a Q&A session, so get your questions for this great panel. Dr. Roder-Dewan.
Thanks, Mark. So I have a minute, but I think listening to Dr. Kaseya makes me appreciate the creativity and innovation that comes from being faced with really serious challenges, and you see that in sub-Saharan Africa, and he raised several of the examples, the responses to that. I've had the privilege of working on service delivery redesign for almost a decade now, and just in the last few years have kind of transitioned to using a service delivery redesign lens for maternal and newborn health in the US, where we have the worst maternal health outcomes, birth outcomes in general, among our high-income peers. The situation appears to be getting worse and is happening against a backdrop of steadily closing labor and delivery units. So in my state of New Hampshire, we've lost 11 of the 26 labor and delivery units. So really a backdrop that can be, I think, overwhelming and depressing. But what I'm learning about the response here in the US, similarly to sub-Saharan Africa, is that by listening to patients especially, and taking that input seriously, and thinking creatively and outside of the box, innovations and solutions are possible, and even possible at a structural level. So, for example, the state New Hampshire has now adopted reimbursement for doulas. And in listening to our patients, we've learned that it isn't enough just to have this really highly effective intervention available in general, but that people want doulas that look like them, that understand their background. And so our program in New Hampshire uses a community health worker model, actually very familiar in the global setting. But it's being adopted here. So we have doula/CHWs who can extend a combination of services to our rural areas. And we have recovery coaches, so folks with lived experience of substance use, for example, functioning as doulas. Grateful for the opportunity to say a few words. Thanks,
Great.
Mark.
Thank you, and connects with the connectivity theme that Dr. Kaseya had mentioned. Okay, Dr. Allen, over to you, please.
So I really loved that Dr. Jean, they're facing incredible challenges in the Afro region, but he's so positive. And Margaret asked us to reflect on, in our own regions, what are the positives that we can be looking for. And I was reminded this morning of the words of Machiavelli, who said, never let a good crisis go to waste. And we need to be looking for the opportunities, even in the toughest of times. I think what we saw in Europe with COVID and coming through that period was that the opportunity we took there was the population got much more used to and comfortable with novel models of care, which enabled us to be a lot more efficient in the way that we use particularly our workforce and the way that we connect with people in rural areas. And reflecting back on the last 10 years that I've been a family doctor for as well, at the beginning, I could send text messages to my 75-year-old patients, but they wouldn't text me back. But literacy is improving as populations are aging. That comes with lots of other challenges as well, but it allows me to be a lot more connected with my panel of older patients than I ever have been before. And that's true across the European region as well. As we're thinking now about, oh my gosh, what do we do with multimorbidity and this aging, ballooning population, and we don't have enough family doctors and we can't train them fast enough. And in the UK, for every 5 GPs that are trained, 4 leave the workforce. So you've got to train 6 to add 1. The current model doesn't work. And so what do we do about that? Actually, it's bringing in allied health professionals and using this moment as an opportunity to move towards multidisciplinary teams. And the population's going with us because things are changing and they understand that finances are stretched. And 80% of people think that the system needs to be fundamentally rebuilt. That's an opportunity for people like us to put forward policy solutions because the Overton window is expanding. So it's a very, very challenging time in Europe and elsewhere, but actually it's a time of great opportunity as well.
Thank you, Dr. Allen. So last but not least, Dr., you're out there.
Thank you. Listening to Dr. Kaseya's, I see clearly that Latin America and the Caribbean face the same challenges, especially in terms of quality and equity and use of evidence. I think in Latin America, during the last decades, we have achieved a lot and we have pretty good averages, I would say. But in terms of equity, we see the gap with those that have been left behind. So from the Inter-American Development Bank's perspective and looking at that in the next years, our strategy to support countries in Latin America is to improve, to decrease the equity gap, to improve quality and improve efficiency. We see the opportunity of working with a system perspective on how to support the countries, not for vertical programs, but to work on how to have a high performing system. And so I think this is an opportunity for us to learn from all of you, from the African continent and from others, how to do this. Because I think at this point, we all have the need clearly identified. And we know the elements of the high-performing system, but how can we do this in a very integrated way from the science of implementation perspective? And it's not easy. We have tried this with Salud Mesoamerica, which is a multi-donor, multi-country, multi-stakeholders initiative. And we have a lot of learnings, but we also understand the challenges that we have to incorporate a system perspective in a high-performing system goal. So one of the components of this that I think we all share, not only with the African continent, is the issue on improving the quality and the opportunity of the data, and more importantly, how the research needs to be linked to the implementation, the actual needs of the country, and how this is going to be. We need to assure that the research is being used and will be used for implementation towards getting results, outcome level results and impact results in health. And also we all need to be more flexible to discuss the research questions, as we have been discussing here and hearing from different researchers, and how this need to be aligned to national priorities, but also to the funders' priorities, trying to understand that this is a process of negotiation and compromising on what is needed from different perspectives. As well, how to be tolerant to failures and to changes in adaptability and flexibility while implementing something like getting to high-performing system or in research. So I think we have a great opportunity. I think for Latin America, this is a turning point in which we should focus more on quality and high-performing system instead of only coverage, which I think we have been doing well so far. But as we know, that's not enough.
Thank you very much. So I heard this connectivity throughout, thinking about evidence connecting not only for health system performance, but data and being connected to health systems to improve equity, access, quality, and ultimately for impact. I mean, that's why these systems are designed. They are self-organizing. They're going to be systems whether we're studying them or not. They are complex adaptive systems that are changing all the time, whether we're studying them or not. And the trust that end users have in those systems is going to depend ultimately on the encapsulated interest. Does the system care for those for whom it's supposed to care? So now we've got some time for Q&A, so I'd love to hear from you all out in the audience, some questions related to the panel. So while you're thinking about some of your questions, what do you think about this role of trust? I don't know who wants to be taking this. This is one of these things, it's a latent construct, it's hard to study, we know how to break it, it's much harder to build it back up. Maybe you can talk about activities that you think are helping improve trust in where you work.
I can just start. So trust is key, and since I also referred to the private sector, I think the trust is lacking sometimes between the public and the private sector, and that is something that needs to be built up very much, because with that kind of partnership, I think we can achieve a lot more. I also want to touch on the subject, on the term of universal health coverage, and I think it's worth spending 30 seconds, because we've been talking of health systems, but health systems for what, and strengthening for what? And I think the way it resonates much better with policymakers, in my experience, is when you say, when you're talking of some achievement in terms of a goal or a target, and that's universal coverage. So we have been working for systems for decades, and I think we were not able to sell it as much when we changed the lingo or the phrasing from health systems towards achieving universal health coverage. And that's where I think partnership and trust is critical. And I think certainly involving the development partners, the private sector, and all of the stakeholders will be critical to be able to achieve that particular target, which is a pretty ominous target for many of the countries.
Thanks, Dr. Siddiqui. I think the Edelman Trust Barometer has demonstrated that business is actually the highest, has the highest level of trust NGOs previously had, but things have changed. Things have changed. While trust in institutions has broadly declined, there are places where trust is still, the leader. Now that will change over time, I imagine, too, as long as businesses, how they operate and act. Will they continue to maintain that trust, or can they grow it? Dr. Iriarte.
I think that the intent of building trusted relationship is not enough. I mean, sometimes we think that it's enough thinking that we will talk transparently and honestly and bring our ideas. And in reality, that needs more than intention, like a planning and having a real strategy on how to build trust. Because it's something that needs time, but it pays off after when we really are able to discuss problems and solutions and put our cards on the table in terms of financing, resources, and abilities, competences, and limitations. So also understanding what battles can be won and which ones cannot. Yeah, this is really important. I have found that when at least we have one or two stakeholders that would like to go through this path of building trust in relationships and having some support on how to do it strategically with some activities that are needed to do that. It's not like it's gonna come out by magic, yeah? And having a very clear, like, how success will look like if we think that we are building a trusting relationship. We have had some experiences on that with countries, with donors, and the IDB in different units and departments. And it took us during our first initiative, like around, for all of us, donors and countries and everything, like about 1.5 years to come from looking the best ourselves in front of the other to discussing really problems and lifting barriers and co-executing and working shoulder to shoulder and being accountable to each other.
Yeah. I mean, you're saying that it's not just a calculation that's happening. There's an emotional component, a psychological state trust is, and there's some vulnerability there, particularly when you're sharing when things aren't always the best. Dr. Rodowan, then Dr. Allen, and then make sure you raise your hand and I'll call on you too.
I mean, I think in the US we have a real crisis of trust when it comes to maternal health right now. You know, we've been talking about bias in maternity care for decades, but our Black mothers are still not being treated the same as others. And I have a pretty simple approach to thinking about trust in this setting. I think if we deliver quality services that meet people's needs, they will trust us. And I think this builds a little bit on what you're saying, Dr. Iriarte. I don't think of it as a separate concept. I think it's very closely tied to the performance of our health systems and our ability to deliver care that meets people's needs.
Thank you. Dr. Allen.
Yeah, just to bring in my personal experience as well in this place, where we've seen that disconnect where people don't trust the health system, but they do trust their provider. And the way that's played out in, probably for most of us, is the rise of populism around vaccines and the politicization there. And so lots of our patients in our practices no longer trust the system, but they do trust us as their care providers. And so the approach to then getting vaccines in their arms is much, we can't have public health independent of primary care. We need to have the two working closely together, the delivery coming through primary care, and thinking much more about outreach into communities rather than people coming to us, that kind of static, reactive model, being a lot more proactive in what we do, segmenting our populations. And so we started hiring community health workers in Oxfordshire, which is a relatively novel intervention in the UK. Because the final two things I wanted to say on this is that trust is earned and trust is relational. It's not a thing you can do. It's very hard for a public health agency to get people to trust it. It's through networks and it's through healthcare workers in the community relating to individual patients. And I think we need to be targeting those who are most at risk of missing out on their screening and their mammograms and everything else.
Thank you. Yeah, some of the 3 C's of trust is competency, character, and caring. Institutions don't love you back, so to speak, and it's the people who do that caring and loving for you that I think is essential. I completely agree. It's visit by visit, interaction by interaction, and that's how it builds.
One other thing about that, which is a challenge that we face, is the old model was that you'd see one provider. The new model is, and they had a vocation, right? They'd become a nurse, they'd become a GP, a family doctor. Increasingly, people they're a GP or a nurse and it's a job for them. And also the roles become a lot more transactional. Like if you're relating to your GP via a chatbot or a text, it's a very different dynamic, and actually you don't have the same kind of relationship. And if you're not seeing them for your asthma monitoring and your blood pressure because you see the nurse, and your bloods are done by somebody else, you might have relational continuity with a team, but it's not one individual. So actually we've just got to be cognizant of the fact that we're actually diluting relational continuity with the introduction of multidisciplinary teams. So there are trade-offs there that we need to be really sensitive to.
Yeah, and dilution with technology. We shouldn't cede too much to technology too quickly, because even taking the history, there's something in the listening that I think is really important as a physician. Okay, if we don't have questions from the audience, oh, someone's got one. Zainab's pointing me, so I can't see very well. Oh, yep. Dr. Mahmood? One question.
Good morning, everyone. I'm Zainab Mahmoud, a cardiologist here at WashU. My question relates to global health. Oftentimes, progress is driven by these global health goals. And I work in maternal cardiovascular health, where a target is maternal mortality. And oftentimes, these are goals that are already achieved by high-income countries when we set the targets, and they seem too ambitious for low-income countries. So what do you think, how do we speak the same language when we try to improve progress and measure performance across health systems in different contexts? What is the best way to set those targets?
Tough question. All right. Dr. Roda-Dewan, this is closest to your work, so I'm going to put you on the spot.
I think I'm a little black and white about this, honestly. I don't think that we should have different targets for different settings. I think from an equity perspective, it's hard to say that it's okay for a woman in a lower income setting to, receive less care during her antenatal visits than one in a high income setting. I've also experienced how complicated that can be when your targets are very ambitious in a low income setting. And I think that conversation really needs to be around sort of setting milestones towards the ambitious target. But personally, I feel very uncomfortable with changing the targets depending on the context. I think people deserve the same quality of care across the world. So.
Any other panelists on?
It's simpler when you use relative targets rather than absolute targets. So, for instance, with the NCD targets, it was to look for a 30% reduction, relative reduction, rather than you must reach a certain rate, because then everyone's on a same playing field, irrespective of where you've started from.
Well, I keep hearing the buzzing, so that maybe that's our clue for us to wrap up. I'd just like to thank the panelists and Dr. Kaseya for his prepared remarks. Thank you all for being here, and we look forward to the next session. We're going to hand it back over to Dr. Crook.